Welcome to the lecture for Crisis Intervention. We'll be talking this time about addiction and crises related to substance use problems. There's a lot of information out there about treating individuals with addiction problems. And for crisis intervention, it's important to be familiar with the research and theoretical literature on the treatment of addiction. But you don't need to be an addiction specialist to help someone in crisis where addiction is playing a role. And it's these instances, crisis intervention instances, that we'll really focus on in this lecture, and not so much the bigger picture of treating individuals with addictive disorders. But starting off, before we get to really talking about crisis intervention, let's spend just a little bit of time talking about some general considerations to keep in mind when working with an individual with an addiction problem. We'll start off with just some terms to make sure we're talking about the same thing. We're talking about substance abuse in terms of a DSM-4 psychiatric diagnosis. It's a maladaptive pattern of use leading to impairment or distress as shown by one symptom in a 12-month period. So for a year, having at least one problem related to your substance use, and that's abuse. And it can be, recurrent use that results in failure to fulfill major role obligations. So somebody's using the substance, and because of the using the substance, they're not going to work, or taking their kids to school, or paying their child support. So whatever, their major role obligations, so what you're expected to do in life, you're not doing it because of the substance use, and it's recurrent, right? Recurrent use in situations that's dangerous to use in, and typically we're talking about driving, and often drinking, drunk driving. If you continually do that, that qualifies for abuse. If you do that over a year period recurrently. Recurrent substance-related legal problems, so getting arrested, having problems with that. So again, it's this maladaptive pattern. So you're using even though there are these negative consequences. Continued use despite social or interpersonal problems associated with use. So if your your romantic partner or people in your family are telling you to quit, and they're saying they're not going to be around you, not going to support you if you keep using, but you keep using anyway, it's causing social and personal problems, then that is abuse. But then the last part is criteria are not met for dependence. Right? So, and usually we think of abuse preceding dependence. If somebody meets criteria for abuse, and then if they continue using and have multiple problems, they meet criteria for dependence, and then you don't diagnose with both abuse and dependence. So abuse is kind of the lesser diagnosis. So substance dependence then is similar, but abuse is one symptom, one of those things we talked about in 12 months. Dependence is 3 or more symptoms in 12 months. So it's a bigger pattern of maladaptive use. And the symptoms can include tolerance, which is needing more of whatever drug or substance you're using to get the desired effect, or if you use the same amount, a diminished effect, so you don't get as high, as drunk, whatever. And then withdrawal symptoms. Withdrawal is a syndrome characteristic of whatever drug. Alcohol withdrawal is different from cocaine withdrawal. But alcohol withdrawal has characteristic symptoms that are similar for everybody. And same thing, cocaine withdrawal is similar for everybody. So there's a characteristic syndrome related to the substance. So you experience that syndrome, or either you experience, withdrawal symptoms, or you use the drug in order to relieve or avoid withdrawal symptoms. Either of those meets criteria for the symptom of withdrawal. So you could have tolerance, you could have withdrawal, or you could have a variety of other symptoms, right? Using more of the substance or using it longer than intended, loss of control of use, so trying to quit and you can't. Lots of time spent getting the drug, using the drug, or recovering from the effects of the drug. Important activities being given up. Keep using even though it causes or worsens a physical or psychological condition. Right? So there's a list of about 7 symptoms. You need 3 of which to have dependence. So note, because there's 7, and you only need 3, you don't have to have tolerance or withdrawal to meet criteria for substance dependence. Usually we think of those as, well, you're dependent once you develop tolerance and you experience withdrawal. And for physical dependence, that's certainly true, but for the diagnosis of the disorder, which encompasses both physical dependence and psychological dependence, you don't necessarily need tolerance or withdrawal. They can be there, but you don't have to have them if you have the other symptoms. Addiction is often used interchangeably with dependence, but again, addiction isn't a diagnosis, so you can't say somebody's been diagnosed with alcohol addiction. It's alcohol dependence, kind of a technicality. And as I just said, you can have, just like dependence, you can have physical addiction, which is characterized by experience of tolerance and withdrawal, and you can also have a psychological addiction, which involves generally an inability or unwillingness to change a pattern of substance use, so to stop using or to use less, despite recurrent negative consequences of use. Right? And psychological addiction can occur with physical addiction or without it. Right? And there's certain drugs where physical addiction is less likely just because of the biological mechanism of the drug. And some saying, well, you can't be addicted to that. And when they say that, they're saying it's unlikely to develop a physical addiction. But any substance that has any kind of psychoactive properties that makes you feel better or different is potentially psychologically addictive and can still be just as much a problem. Some other terms, an enabler. So this is a somewhat controversial idea here that an individual or individuals socially related to the person with the substance problem engages in behaviors that make it possible for the addict to continue their problematic pattern of use. So they enable the use, right? So this assumes that without this enabling influence, that the addict, the person, would suffer consequences of sufficient severity that they would then stop using. Right? The only reason they're still using is because you're helping them or letting them. Right? It's not clear that this is true. Right? It may be true in some instances, but not always. The evidence isn't super solid on this. And the other thing to keep in mind is it is possible that it's true in terms of, they would stop using if you didn't do these enabling behaviors, but they would stop using because without the enabling behaviors of others, they might die. Right? So if they say, well, they go and get drunk and then you drive them home, you're enabling them. Well, if the person didn't do that, they might get in a wreck and be dead, which would stop the use, but maybe not your goal for somebody you care about. Okay. That being said, it does seem clear that in some instances, individuals do serve to kind of buffer the negative effects of an addict's substance use. Right? So lying to their boss about that, they were sick when really they're strung out. So that does happen, but it's important not to simply see the person. Just as it's important not to see the person with the substance problem as an addict, right? Oh, that's all they are is an addict, and I'll define them by their addiction. It's equally important not to view significant others as enablers, and not let that label become reified as who and what they are, right? Because the labels do facilitate communication, because it's easier to say, oh yeah, they're exhibiting some enabling behavior, rather than saying they're doing certain things that allow the person to continue their use. It's just faster. But using these labels also masks the complexity at play, right? The enablers' behaviors don't occur in a vacuum, right? They're influenced by multiple variables, including probably behaviors exhibited by the person with the substance use problem. So there's a dynamic involved. And it's not just, oh, this person's an addict, this person's an enabler. I get it now. I understand it. No, it's more complex than that. But yeah, it is important to recognize that the individuals in the life of someone with a substance use problem can play a role in maintaining the problem, and because of that, they can also play a role in potentially ameliorating or resolving the problem. Okay. A related idea, it's also somewhat controversial, is codependency, which suggests that addiction occurs in a relationship context where both people are getting their needs met because of the maladaptive pattern of substance use. Right? So the idea here is that the addict, if you will, is dependent on the other person, who we may think of as the enabler, for taking care of them, covering for them. But then the enabler, the other person who's doesn't have a substance abuse problem, is also dependent on the other person, and they're dependent on them for more kind of psychological reasons in terms of deriving a sense of purpose and self-worth from taking care of this person. Right, so I need you to be ill for me to feel good about myself. So I am dependent on you, and because you're ill, you are dependent on me, and so there's this codependence. And that dynamic has been observed in some dyads, some couples, some families, but it's not always the case. Right, substance abuse population is incredibly diverse, and lots of different dynamics at play. But that's one that does seem to occur with some frequency, so important to be aware of. Okay. Okay, getting more to intervention stuff. So there are multiple treatment theories out there for working with individuals with substance use problems. I want to talk about the one that I think is most relevant to crisis intervention. That's this idea of a transtheoretical model of change. And the idea behind this model is that intervention will only be effective if you meet someone where they are regarding their desire to change some behavior. Right? And this model was built originally on individuals who were smokers. It was a smoking cessation program where the authors developed this idea. But it seems to apply to a wide variety of behaviors, and especially behaviors that have kind of an addictive profile. So it's just there's different stages of change that people are in, and depending on what stage they're on, you do different things. So and you go from I'm not going to change to I'm ready to change. So you start off with pre-contemplative. The pre-contemplative stage, they're not even considering a change. So they don't see a problem with whatever behavior that you think or society thinks should change. And this is where a lot of folks in crisis may be coming in at. Especially if the crisis isn't related directly to the substance use. They're not coming in because they want to quit. They're coming in because their substance use has gotten them into trouble somewhere else. So they may not be thinking, oh, I need to change. So when that happens, what you do, the intervention, is you validate where they are. Okay, so yeah, for you right now, it doesn't seem like it's a problem. But you also want to note that the decision about whether to change belongs to them, right? And by doing this, say, hey, it's your choice if you want to not do this or not. And by saying that, you're avoiding this power struggle, saying, I'm going to make you change. The other thing is it introduces the idea that change is a choice. And if change is a choice, it's possible. Because one thing that happens sometimes is people get so caught up in certain patterns of behavior, it no longer seems that there is a choice, and that it will always be this way until I die. I kill myself. And you invite them to share what they're thinking about the problem, and then also verify their understanding of what's probably going to happen to them if they don't change. So it's like your decision. You don't want to lose. You don't want to change, but you're coming in here today because you got your 30 DWI and they took your car away, and you can't figure out how to get to work, and you want me to help you solve the problem of getting to work. Let's just make sure you understand if you borrow somebody else's car, you drive illegally, you know what's going to happen. And I'm not telling you if you do these bad things. I'm not going to preach at you. I'm going to ask you, what do you think is going to happen? So I'm going to have you think about it rather than me tell you, which again, trying not to get that push-pull. But the idea is, as they start thinking about these things, that may move them into the next stage, at least get them thinking about, well, I guess change is possible. This bad shit might happen. Maybe I ought to think about changing, right? So you might also meet some people who are in the contemplative stage. This is when they're ambivalent about change. So they're like, I think I would like to stop using or use less, but no, I don't. So again, ambivalence isn't, I don't know how I feel. It's feeling strongly both ways. Yeah, I want to quit, but no, I really love it. I don't want to quit, right? So in terms of interventions when they're in the contemplative stage, a lot of the stuff, same as above. So you're still going to do all the stuff we talked about in terms of validating, and it's their choice. But then you're going to add an exploration of the costs and benefits of change, and then also talking about potential positive outcomes of change. So before we kind of said, you understand the bad stuff that's going to happen if you don't change. Now we want to flip it and say, okay, if you did decide to do this, I wonder how life would be different. If you didn't spend, $30 a week on cigarettes, I wonder what else you could do with that money. Those kind of things. And then the next step in the model would be if they move to preparation. So here, maybe they've tried changing some, and they're planning to try something within the next month. So they've moved beyond the ambivalence to, okay, yeah, I think I'm going to do it, and now I'm going to prepare for change. And I may have made some small changes, right? So in terms of substance use, may have experimented with going to a bar and not drinking, or having one drink and then leaving, and just seeing, they maybe saw how that went. But now they think, okay, what am I going to do bigger? So here's where, in terms of intervention, you start talking about social supports and coping mechanisms, and encouraging small steps, right? So getting things in place to support them for any kind of change, which then will help them move into the action stage. And this is when they're trying something new. So you prepare, you come up with some plan, and then now they're trying it, right? And here you want to support their sense of self-efficacy. You're trying to do things. That's really great, and it's an experiment. And you're not that okay. You've done it, yay! It's you're doing it, and there's a difference. It's a process, not a endpoint. Here you can also address issues of loss related to the change, which seems counterintuitive sometimes to ask people, what do you miss most about getting drunk? What do you miss most about getting high? And people think, well, don't ask them that. They're going to reminisce and they're going to go back to getting high. No, they're going to think about it already. So you want to talk about it with them in a therapeutic setting. And then the other thing you can do, if they say, oh, I miss feeling really relaxed and calm, then you can say, okay, so it's really important to you to feel relaxed and calm. I wonder how else you could feel that way. Right? Given that you've told me that there's all these other negative consequences of using it that you don't want. Right? So if you don't want to use this drug, the substance anymore, but you still want this benefit, how else can you get that benefit? Right? Because the benefit's it's not bad to feel relaxed and calm. It's not bad to feel confident in social situations if that's why they're using. But there are other ways to do it other than chemically induced. Right? And then the maintenance stage. So now they've been able to sustain the new behavior for some period or periods of time. So you want to develop a follow-up plan, reinforce the rewarding nature of change. Doesn't it feel good to do this? And tell me all the best things about the things you've done about not using, and instead of using you decided to do this. Tell me all the best things about doing this new thing. And then the other thing you do is plan for relapse. You say, well, why do you want to plan for failure? You're going to plant the seed that they're going to relapse. Well, they probably are going to relapse. And it's important to talk about that and recognize that and say that this is what happens with addictions, especially powerful addictions, that you don't quit cold turkey the first time. Most people don't. You might. Hey, good luck to you. Most people don't successfully. The important thing is when you do slip up and use again, to not see it as starting over, right? To view it as, okay, that was a slip. What do I need to do to make it less likely that I don't slip again, right? Because if you view it, I slipped. Oh, I clearly can't ever stop using. All this is crap. I'm not going to try anymore. And that's what happens if you don't plan for relapse. It's one little slip is seen as the end of the world. So you plan to say, okay, yeah, you might slip. You probably will slip. When you do, what are you going to do? How are you going to get back on the plan? Right. So then the last stage that you talk about is relapse. So when they come back and they have relapsed, you help them identify why they relapsed. What's the trigger? So okay, so you relapsed. What was going on before you used? Why do you think it happened? And then you assess their current motivational stage, see where they're at, and then you meet them there. And you probably do something to help them deal with whatever trigger or triggers they've identified in the future. Okay. So keeping this model in mind, I think, is helpful for crisis intervention because you'll probably be meeting people that are largely in the pre-contemplative and contemplative stages. And so having that attitude of my job is to move them along the stage, not to necessarily get them clean today, because that's not realistic for crisis intervention. But if they become more realistic goals, I think it fits well with this model. Getting on to crises, in terms of types of crises that people might present with related to substance use problems. Legal trouble, common, right? Either they could have been busted for possession or theft if they don't have the financial resources to support their habit. The most common way to do that is to steal stuff. Potentially violent crime. Higher rates of violent crime are associated with substance use for a variety of reasons related to the impact of the substance use on impulsivity, but also just related to the subculture you get into in the drug culture violence is more common because people are already doing illegal stuff. So if somebody's going to beat you up for your drugs, who are you going to tell the police, hey, they beat me up and stole my drugs? No, of course not. So there are fewer rules of society at play in drug culture oftentimes, which puts people at risk to be victims of violent crime and other things more often. Might also get involved with CPS. They may come in and they've had their children taken away. So that might be why they're in crisis. And the children are taken away because they have this chronic substance use problem. Okay. Might be financial problem. They owe people money, or they've lost possessions because it's been stolen, or they've had to sell things to support their habit, and now that's why they're in crisis. Very commonly, it'll be interpersonal problem, and potentially domestic violence, and either that they've committed partner violence, been the perpetrator, or that they're the victim, maybe because their partner's using as well. It could be that their family's threatening to leave them. Maybe the family had try to have an intervention that didn't go so well, and that has led to this current crisis. So all these things are related to somebody coming in not technically because I'm in crisis because I want to quit. It's because of my use. I've had these other crises, right? So there are crises related to substance use, where substance use isn't technically the crisis. But it might also be that the crisis is they're intoxicated, and this is usually if they're in crisis because they're intoxicated, it's because they're having a negative drug reaction, a bad trip. So you might get this. This is more likely with distance intervention, a phone crisis center. Somebody might call in if they've taken some drugs and are having a negative experience. That certainly could happen, and that's one crisis you might experience. And that would be one that's more related directly to use, and not as just kind of a consequence of a pattern of use. But the point here when talking about these things is again that substance use itself doesn't usually present as a crisis. I'm in crisis because I'm using. I'm in crisis because my use has led to these other losses or threats of loss. Right? Okay, so when you get to crises related to substance use, the James Gillen model, I think, can be helpful. So we think about the assessment of client functioning and how it might look a little different with individuals from this population, which again, it's a diverse population. But some things to think about. Assessing client functioning, we think about assessing affective functioning, behavioral functioning, and cognitive functioning. Right. So under affective functioning, identifying the primary emotion is if it's angry or anxious or sad. Anger is a common reaction to being challenged about problematic substance use. Right. So you need to be prepared for this possibility. If you're going to be asking someone about their drug use and asking questions that suggest that their use is a problem, they might get really angry at you. It's important not to get overly defensive or frightened by this. I mean, you keep yourself safe and you take appropriate precautions, but often the anger is kind of this short burn flare where it then devolves into sadness and shame and self-reproach. And you can also, often use what I call psychological judo. Right? And so in judo, when somebody comes at you, you don't hit them back. You move out of the way and let them take their momentum. So same thing emotionally. If they're going to be angry, you don't have to, fight back at the anger or take the anger. Just let the anger go by you. Well, I can see you get really upset whenever anybody asks you, or anybody suggests that this is a problem. So again, I'm not fighting you. I'm not taking it. I'm just going, okay, wow, look at this. I'm observing the process with you that, wow, you have a lot of anger. And again, that anger, like I said, is often masking deeper feelings of anxiety or sadness. The other thing to kind of keep in mind in terms of assessing affective functioning, if they have a family history of substance abuse, which is not uncommon. So example, if they're the child of an alcoholic, it's also possible that they've formed some maladaptive schema related to emotional expression. It's one of the things the research suggested about children of alcoholics is that they learn things like don't feel and don't tell people how you feel, don't trust people, right? And if that's the case, it might impair their ability to accurately identify or express how they're feeling. So you may need to do some kind of Gestalt type, emotion focus type work with them on this. Okay, right now I want to ask you how you're feeling. You can't tell me anything other than hungry or angry, and I think there's other things going on. Let's just take a minute, and I want you to think about your body and how you're feeling, and you kind of do that sensation focus stuff to help them identify their feelings, get them in touch with that, and that might help in terms of their mobility to do something about whatever crisis they're dealing with. Because if they're experiencing all this emotion but have no words to label it, that can be incapacitating. Right? Then all this is about assessing their current affect. So what are they coming in with? The other thing to think about in terms of this population is you have to consider the potential impact of substance use on the affective expression. Most substances that are abused have an impact on the brain's emotion processing centers, right? Because they make you feel differently. And depending on the extent of their use and the recency of their use, if they're maybe high now or on withdrawal now, they may exhibit some atypical affective functioning, right? You may have a chronic meth user who's very quick to anger, and that's related to their substance use and not so much something else in their family history or dynamics. Okay. In terms of behavioral functioning, we talk about in terms of the crisis, are they approaching it or avoiding it? Avoidance of problems is probably to be expected with this population, right? An avoidant coping style is often related directly to their problematic use of substances. Drink to avoid worrying about work, right? So whatever the crisis is, more likely than with other people, if they're a substance abuser, to have kind of an avoidance oriented behavior. And the other thing to keep in mind is that it's possible that whatever their primary coping mechanism is, may not be an option for them, because their primary coping mechanism is likely substance use. And so they're coming in and they're afraid they're going to lose their kids, and they're really anxious about it. And you say, okay, well, what have you done in the past? Well, I got really drunk. Okay, well, that's why you lost your kids, so we can't use that. So you have to keep in mind that your usual go-to thing of, well, what's worked in the past? Their immediate answer may not be something that is viable for them this time, because it may actually make the other problems worse as well. In terms of mobility, again, thinking about the impact of substance use, again, depending on the extent and recency of use, there may be an impact on mobility. If they've caused brain damage to themselves, they may be less able to efficiently organize their behaviors. Or if they've recently tried to quit, withdrawal symptoms can also impact their mobility. Their ability to act on whatever kind of plan you're coming up with. So you have to think about that as well. In terms of cognitive functioning, think about transgressions, threats, and loss, and they've probably experienced all of these related to their substance use. In terms of thinking about negative things that they've done and that have happened to them, and shame, feelings around that, threats that either I might lose my kids, I might lose my family, I might lose my job, I might lose my freedom, and then they probably also lost some things already, lost some relationships, and then also potentially possessions and other material things. And they may have thoughts related to that. And again, we come back to the impact of substance use. Depending on the recency and extent of use, they may not be able to think very clearly. Drugs can really screw up your brain and make it hard to think clearly. So you may have to even be more patient and systematic and concrete, especially concrete with this population, if they've had extensive abuse. The other thing that is often discussed in literature is the use of defense mechanisms, which I often think of as being kind of related to cognitive functioning in terms of denial, displacement, fantasy, intellectualization, basically coming up with these different cognitive strategies for justifying in their substance use. Because again, this whole thing about dependence and abuse, bad. It's not that, I get high all the time and it's not really a problem. Things go well for me. I've got a decent job and I've got lots of friends. That's not substance dependence, according to DSM. If you can use and it doesn't cause problems, it's not a diagnosis. It's a diagnosis and it's a problem because it's causing problems in your life. But you keep using anyway. And that's incongruent. Why would you bang your head against the wall? Well, you have to come up with these kind of cognitive strategies to say, well, I'm not really doing it, so I'm denial or intellectualization. Well, what's going on here is that I have this use problem, and I have these problems, but I only have these problems because society hasn't accepted that this is an appropriate thing, and that's what needs to change. Right? So they may have a lot of kind of distorted cognitions that they use as defense mechanisms to justify their ongoing behavior, which they know at some level is causing problems. In terms of intervening, using the James and Gilliland model, step one, defining the problem. So one of the key things to think about is substance use the crisis? Right? And it may or may not be, right? Because again, people will come in crisis with a variety of problems, and a lot of times they have a crisis problem and they have some sort of long-term problem also, and it could be substance use, could be some other psychopathology. And our job as crisis interventionists is to help them solve the crisis, but also put them on the path to help with the long-term problem. But we can't solve that long-term problem in crisis intervention. So substance use may not be the crisis. Doesn't mean we can't talk about it some, but our primary focus has to remain on what's the immediate issue and safety and returning them to equilibrium. Right? But we also, in defining the problem with them, we can talk about, well, what's the relationship between substance use and the crisis? And this is where we kind of bring in that stage of change model and see, do they make the connection between the current crisis and other problems in their life and their substance use, right? And the main thing is not to go in being combative and confrontational. Don't you see this, you stupid idiot? But asking them questions and drawing it out of them to help them make those connections and see if they make them. And if they make them but they're not ready to change, they're probably not going to change. And so that's if that's the case, okay, yeah, I see this best is happening, but I'm not going to quit. I can't quit yet. Okay, well, if you're not there, then the stuff we're going to talk about in terms of what the problem is that we're going to work on has got to be separate from that. I'm going to tell you, it's that these behaviors have caused these problems. So they'll probably cause problems again in the future. But if you're not willing to work on that, I can't force you. So we got to focus our energies elsewhere. We'll talk about ensuring safety. A variety of things to consider with this population. Potentially, if they come in intoxicated, you don't want to let them leave. Right? So if you think they're a danger to themselves or others because of intoxication, they're going to go out and potentially hurt somebody driving drunk or high. You do what you do when you think people are a danger to themselves or others. You call the police, right? There's also a danger of withdrawal. Again, depending on which drug, how long they use, and how heavily they use. If we tell people, okay, yeah, you need to quit, or they come in saying, I decided to quit cold turkey yesterday. Okay, that may be a really dangerous thing to do, and you may now experience seizures and death. Right? If they're heavy users of certain substances, including alcohol, they need to go to a detox program where they can manage the withdrawal symptoms without dying. Right? So we have to assess that. If they're starting to experience withdrawal, if they decided to stop, do we need to bring in medical professionals to keep them safe? And then obviously the risk of harm to self and others, I was talked about with intoxication. But even if they're not high or drunk or whatever right now, we know that substance use increases the risk for both harm to others and harm to self. So you need to make sure and do an appropriate evaluation and take the appropriate steps, as we've talked about before, in terms of partner violence and self-harm and all those things. In terms of providing support, a lot of the same stuff. So a non-judgmental attitude. So it's not, okay, you're an addict and therefore you're a bad person and you're weak, because it's all in your head. And if you wanted to stop bad enough, you would stop. And if you have those kind of core beliefs, it's going to come across and probably not going to work well unless maybe they're a masochist. So, you don't want to endorse substance use by any means, but you don't want to demonize it either, right? And if you can think of it as, for them, it's a coping mechanism. It's not some expression of evil. There's a lot of evil done related to substance use, don't get me wrong. But when people use, it's usually to cope with some problems that they're having. Leave it at that. Then, related to sport, I have a question here, which is your first discussion question in terms of therapist substance use history. Do you think that to be able to provide adequate support and identify with someone suffering from a substance use problem, that the therapist needs to have or needs to be a recovered addict themselves? Or do you think, people who are recovered addicts shouldn't do this work, because the person will see them as working on you're trying to make me like you, and it's not about me. Maybe they're aware that there's too much transference stuff. So I'll repeat that question at the end. But what do you think about therapists with a substance use history themselves? If they should have that history to work with this population, or if they shouldn't, or either way, if they should disclose it, or if clients asking, should you not disclose? Okay. The next step in the model is examining alternatives, right? Which again, kind of using that the attitude of the stage of change model when examining alternatives is really helpful here, I think. But certain things to think about with this population in particular, thinking about the quality of the social support system. How many people in their social support system are clean, right? Because they may have burned a lot of bridges, and people who aren't users may have distanced themselves from this person, and they may have borrowed money, stolen things, caused harm, to where people that you think should be there for them aren't able to be there for them right now for right reasons. And so the people that are there, are they reliable support systems, or are they in recovery themselves? And if so, how dangerous is that to be the person that they're really relying on? And a side note related to this, something I thought was interesting. Research indicates that addicts whose families provide financial support are more likely to relapse. You think, they're getting back on their feet, so I'm going to make their car payment for them right now. I'm not saying that's right or wrong. I'm saying that when families provide financial support, relapse is more likely. So the kind of support that you're encouraging them to seek may be important. So they need social support, but maybe not so much financial support, because if given money, apparently they're more likely to use it to purchase substances. When thinking about the alternatives, things to do, another thing to think about here is the definition of equilibrium, right? Because we're thinking about, what can we do to restore you to equilibrium? So thinking toward this goal, another kind of question for you, which not a discussion question for this lecture, but something to think about. Does equilibrium require cessation of substance use? And I would say, no, not necessarily, right? Some people might be able to, depending on the substance they're using, their pattern, all this stuff, getting them back to equilibrium to where they can function enough to resolve the current crisis. If the current crisis is related to, not having a place to live, they might be able to resolve that crisis without stopping using their substance. And again, we don't want to say, using drugs is fine, but that it may not be the target of our intervention. So when thinking about alternatives, one of the alternatives might be, you need to be able to function enough to do this. What's the least amount of drinking or of smoking that you think you can do that will allow you to go to work? Do you think you could just get high on Saturdays? Right? And people might balk at that, but again, our job is to restore equilibrium. And we're not saying that it's okay to get high, but right now we need to make sure you have a place to live. And doing that might not involve quitting. Okay. Another thing in terms of examining alternatives, inpatient versus outpatient as options. It's not clear that inpatient is more effective. It was often been thought of as kind of the gold standard. In terms of gold, it is more expensive than outpatient. But looking at the long-term outcomes, not clear that there's a difference. With the caveat being that if somebody's doing only outpatient, they may need some inpatient initially for detox. Depending again on the substance they're using and how long they've used it. Otherwise, it doesn't seem that one's much more effective than the other. Making plans is the next stage, right? Which an important point of emphasis here is relapse prevention. So, if you're making plans for cessation, if that is part of one of the alternatives you looked at and part of the plans you're making, you need to make sure and plan for relapse because, as I said, relapse is the rule, not the exception. In terms of obtaining commitment, again, think about what stage of change they're at. If you're trying to obtain commitment related to their substance use behavior, where are they at? Because if you're getting commitment to do something beyond what stage they're in, what they're ready for, it's doomed to failure. Right? The reason that people say, "Oh, well, addicts are all liars," well, they lie because people keep asking them, "Are you going to stop using? Have you stopped using?" What do you want me to say? You want me to say this, so of course I'm going to say this. So if you don't demand a truth that they can't give, I guess is what I'm saying, and give them space to be honest about what they're ready to do, and get them to commit to that. So what can you do related to changing this behavior, rather than you have to change the behavior? Are you going to do it? Well, if I say no, will you let me out of here? No. Okay, well then yes. Right. Okay, so summing up, important to keep in the back of your mind stage of change related to addictive behaviors and meet them where they're at. Substance use, again, is not always the crisis. And so, again, that may not be the focus of your crisis intervention. It's going to influence the decisions you make, and it increases risk factors for a lot of things. But just because they have a substance problem and they're in crisis doesn't mean you have to solve the substance problem now. Okay. But as I said, it does increase the risk for harm, so you're on kind of heightened alert. Obviously in crisis you're already high alert, a little bit higher now because substances are involved. Okay, for your discussion questions, two this time. One, I already mentioned, in terms of do you think it's important for therapists to have a history of overcoming addiction or substance use problems themselves? So, yeah, I think it's important, and here's why, or no, it's not important, or no, they shouldn't. Whatever your answer to that is, and kind of why you think that way, feel that way. And then the other question is related to not so much just crisis intervention, but treatment of addiction more in general, in terms of the goal. And this is a debate that's in the literature. One reason I want you to talk about it and think about it is whether or not the goal should be abstinence all the time, or if for some individuals it should be controlled use of the substance. When we talk about this, usually we talk about the legal drugs, so alcohol. So somebody suffering from alcohol dependence, if they're a long-term client of yours, do you believe that treating them involves getting to the point where they will never drink again, and that they have to come to the realization that they can never drink again, which is kind of the AA model? Or can people who have had problems, who have abused alcohol, who have used too much, who have met those criteria where it didn't meet their major social roles, they've been this way before, can they get to a point where they can drink responsibly? Do you think that's possible? And do you think it should be a goal of therapy if that's what they wanted? Okay. So those are the two discussion questions. That's all for now. Take care.